So we're doing interviews at the 2018 Global Healthcare Conference at Loma Linda University in Loma Linda, California. Today I'm interviewing Dr. Tiffany Priester, who's a cardiologist at part-time in Malawi, and I'll let her tell you something about herself. Dr. Priester, can you tell us a little bit about your role currently in Malawi, and then we'll go back to your history of how you've been working in Malawi.
Sure. Right now I take 2 trips a year to Malawi, both about a month long. And when I'm there, I'm the only cardiologist in the country. They've been unable to find a cardiologist to replace me, because I used to be there full-time. And so I continue to go back twice a year, trying to take teams of residents, medical students, and other healthcare professionals if they want to go along with me, and try to see all the cardiac patients that need 6-month follow-up for their ultrasounds for their heart issues. And then return again 6 months later to do the same thing.
So when did you decide to become a missionary? What got into your being that decided you to be a missionary?
So I wanted to be a missionary since I was small. My father was a pastor and my mother was a physician. This is my mother. And we used to go on short-term trips, and we used to listen to the mission features and the mission spotlights here in Loma Linda, where I grew up. And I decided a long time ago that I was going to go through the program. After medical school, I signed up for the General Conference missionary program called Deferred Mission Appointee. Once I finished my cardiology training, then I actually took a full call and served in Malawi for 5 years.
And can you tell us something about the country of Malawi, what you're doing there, the programs in Malawi?
Malawi is a country of about 16 million people and very little health care. Always on the bottom of the scale for people having access to health care, the doctor-to-patient ratio, how many specialists are in a country, and how many poor people can reach health care. Most of the population is in a rural setting. Most of the population makes less than $1.25 per day. So we created an intensive care unit as well as a cardiology clinic, which were fully operational at this point. Of course, the cardiology clinic has intermittent coverage. We're looking forward to doing projects to get more cover there. What we do is take care of patients that are in our catchment area, people who are able to make it into the hospital. I work mostly for Blantyre Adventist Hospital, but I also take some time to go to the local government hospital called Queen Elizabeth. I do an outreach clinic as well to Malawi Mission Hospital, as well as the Adventist Clinic in Lilongwe. What we would provide is cardiology consultations, stress testing, echocardiograms, pulmonary function testing, and chest x-ray interpretation, and try to help people figure out, maybe if they have a complaint, what their complaint is about, get them on medications, and teach them about the illness that they may have.
So my understanding is Malawi sits in a kind of a narrow strip, and Mozambique kind of wraps around Malawi, so that you have a number of people from Mozambique who come in when you're there, because it's closer to go to Blantyre than it is to go to the capital city of their country where there's a cardiologist.
That's right. And all of our hospitals have a good enough reputation, the hospitals in Malawi, that patients would come across the border from Mozambique. There are not a lot of high-quality healthcare centers in Mozambique close to the Malawian border, and so I would also take care of patients coming across.
I visited you while you were there, and I recall one patient coming and saying that they sat at the border 4 hours in order to come across to the hospital, and then the same repeat process going back. That's quite a feat.
It is. There's a number of situations that I make quite a difference in, and heart failure is one of those cases. Diabetes is another case, and sometimes those two diseases go hand in hand. And so the patients that would be willing to spend that kind of time coming across the border to see me are often our diabetic patients that have advanced heart failure. And the local Malawian and Mozambican physicians have a lot less knowledge about how to treat more advanced heart failure, about how to titrate medications for heart failure and assess volume status. And those patients are often willing to put in a significant amount of their own effort to come in and see me, because they do feel quite a bit better when I'm finished titrating their medications.
Now, my understanding is you were able to start an ICU, a modern, up-to-date ICU in the country of Malawi there in Blantyre. Do you have any experiences you could share with us?
Sure. We did start an ICU. It is relatively modern. It is not up to the speed of what we would see, in a United States ICU, but it is certainly roughly equivalent to what you might have in other African countries as far as an ICU goes. We do have ventilators. We have medications for life support, to hold up your blood pressure, for treating shock. Those type of facilities are available. We have a relatively high percentage of patients with tuberculosis and HIV, and then in addition, we have patients that might have not have communicable diseases, but have trauma, surgical procedures that require intensive care after they're finished. So we did start a 4-bed ICU there that continues to operate with a missionary who's come since I've been there, Dr. David Saunders. Continues to run the intensive care unit and take care of critically ill patients that need more advanced life support that's not available at other hospitals in the country.
Yeah, I think that you've even had people transferred from Queen Elizabeth, the big 1,000-bed hospital that's fairly close by. I remember there was a lady that was eclamptic that was transferred to your hospital.
Absolutely. We occasionally provide a space for patients from the government hospital that provides free care. And we've had multiple patients. This lady in particular had been in labor in the bush and been gone into eclampsia, which has seizures and is life-threatening for the mother and for the child. Along the way, she went to her local clinic. She was transferred to a regional hospital, transferred to the government central hospital. They had tried to control her seizures there, but her IV had fallen out, and she had been under continuous seizures, which we call status epilepticus, for about 24 hours by the time they decided to send her to us. She'd already had 1 or 2 children, and this was her 3rd child. She was only 23 years old. And she was completely unconscious and in having seizures when she arrived for us. We were able to get her onto a breathing machine, get her the medications to calm down the seizure. Unfortunately, there was a fetal demise on the premature infant that was born. After 2 days on the ventilator, we were able to get her weaned off of everything. All the seizures had settled, and she was able to walk under her own power back out of the hospital again.
Wow. So it sounds like you have had what I would call miracles happening with your work there, as well as having the more advanced medical support that you're able to offer.
Absolutely. We say the motto for the hospital is "We care, God heals." I provide the most medical care I can provide, and after that we provide prayers, and we believe in the Lord. There have certainly been cases where I'm doing everything I can do as a physician, and I look at the patient, and the indicators are all very poor. There's no urine output, the blood pressures are quite low, the blood tests show that organs have started to fail, and more organs are failing, and I tend to prepare the family and say, this doesn't look good. Multiple organs have failed. We're on maximum support, life support for what I can provide, and it still looks as if things are deteriorating. And oftentimes we'll have a prayer session with the family to say, the doctors have done what they can do, the rest is in God's hands. And we have had patients who turn around and get extubated and get off all their medications and walk out that medically I think shouldn't have. Medically I think they should have passed away or succumbed based on the parameters that we look at as physicians. But after those prayer sessions, things change, the urine starts coming. Of course, we don't know about miracles, but I personally believe that many of the cases have had miraculous healing.
So we're down to the last part of this conversation. Is there something that you'd like to make an appeal? Are there projects that you'd like to talk about before we close here?
Sure. For Malawi itself, we have 2 current projects that we're working on. One is a project to create a mobile cardiology clinic. I would like to be able to provide care at more than one hospital, and like to provide care out into the poor areas that don't have access to come in to see me. So I'd like to set up a truck that has a treadmill in it and an ultrasound in it and the basic bed, a computer for me to sit at, some medications, and a little point of care chemistry testing machine to check creatinine, where I can go out and provide all that care to the poor population. The second project that we're looking at is a maternal fetal center or a mother-child center. We have an ICU, we have a new dental building, there's pieces of Blantyre Evanes Hospital that have been improved, but what we're lacking now is a center of excellence for maternal and child issues. So we're trying to raise money to create a center. We have a building designated, and we have the plans, and we're raising money for that. In addition to the projects in Malawi, I've been a missionary. I've been in the field for 5 years. I know what it's like to be out there. I know that our missionary doctors are burned out. They're working 24/7 without relief. And then when they finally get an opportunity to come home for 1 month out of the year on their annual leave, there's the concern about what happens to the patients while they're away. So another project we're working on is how to link physicians in the United States or Adventists abroad to try to provide relief to our physicians who are missionaries out there. Whether it's coming while that missionary is still there and just working side by side with them, or whether people are willing to cover for 4 weeks while one of our missionary doctors is away. We have nearly 20 missionary doctors out there, so we need nearly 20 people every year to try to cover those hospitals.
Thank you so much for the time that you've taken, and we enjoy your stories. Hope that we can see you again.
Thank you.